Hello students, I'm going to talk to you a little bit about caring for the dying patient and the family, and then caring for yourself in terms of how difficult sometimes palliative nursing care can be. Your textbook does a pretty good job of really outlining the domains of palliative care, and so I think if you review through that, you'll be able to see some of the common things that you should be prepared to know. We have, I think even in fundamentals, covered post-mortem care in the past, and so we've had some exposure to that. We've also talked a little bit about some of these concepts related to family care in fundamentals, and we also have covered some detail about cancer care in general last semester, and some of that content focused on, working with patients that are having terminal illness and those kind of things. I do want to kind of reintroduce you to a few of the forms and some specific things in North Carolina just to be aware of, and so hopefully this will go fairly smooth. This is just kind of some historical background on, life expectancy has increased over the last few years, and it's now at the average age people living to be 78, and this is going to be even larger than normal in the next 10 years. Just because of so many people that were born after World War II are now at a very, beginning to be at a very elderly age. And so that's going to complicate matters in terms of how much expectations and expertise that we have in taking care of the aged, but also taking care of patients that are older and dying. So when we talk about palliative care, and we've talked about palliation of treatments when we talked about cancer patients, the focus of palliation is to deal with relieving symptoms. And that can be stress, that can be emotional pain, that can be physical pain, that can be ascites on an abdomen that's, causing too much pressure and discomfort, but other things that we have a physical way or a psychological way to interact with the client and provide support to them or their family that helps alleviate some of those symptoms. So sometimes you hear the terms palliative care and hospice care all mixed in together. That used to be sort of a big divide, where hospice care was like, you can't go into hospice unless you make yourself a DNR, and that was a requirement. And most hospice homes that house people didn't traditionally ever provide much high-end care or even palliative care. They were more like, you came there, you were there for a few weeks and at most, and then you're really in the actively dying phase. Hospice care has traditionally been provided more in the home for many, many years, and then as this growth of, we don't just let people die and give them lots of pain medication, we can treat some of their symptoms for the last several months of their life and make them have the most comfortable and dignified death experience. And in that regard, we can ease a lot of their suffering. Just to continue, hospice care now is really a little more broad-based in terms of acceptance with all types of palliative care measures. The definition for a person to be able to be admitted to hospice care is they have to have a doctor certify in writing that they have a terminally ill type condition or diagnoses, and that they likely have less than 6 months to live. And so most of the older patients that we see, hospice care is provided as part of Medicare. And so those patients are fairly easy to cover. And you might ask, well, what if somebody is on hospice care for 6 months and they don't live? I mean, they still living after 6 months. They have to be recertified yet again. And you know, there are some chronic conditions like COPD that people are having bouts of up and down, and they may go back and forth. And so that's one of the diseases that sometimes it's chronic in nature and it is going to be terminal in nature, but it's very difficult to predict. So at a certain point in time, if somebody just kind of is not, they might recertify them once if they think that they're close to, you know, end of life, but if not, they may not keep them on hospice care. Hospice care can also be provided at home, which is traditionally where it used to be. Now the hospice care workers, whether that's the nurse and or the health workers that maybe bathe patients or do physical things for them, actually go into the skilled nursing facility where the person is a resident, and they provide the services, and then they have a contractual arrangement for, you know, paying for that bed to the nursing home, and then they're billing Medicare for the coverage for their care. So there's a few nuances that the social worker would meet with them and talk a little bit more about how all that works. So just be aware some of that is totally out of your control, but there are some rules about being on those things that have to be in place. So is hospice care really different than hospital care, and how does that differ? Or is it different than just being in a skilled nursing facility or not? Because hospice care is a team approach, it is going to be different. You can kind of see in this picture here, this is a person that is in a hospice home. They usually are in normal kind of looking furniture. They're in a bedroom that looks more like what would be in your home at home. So the idea is to make that surrounding as comfortable and as home-like for the person as possible. And many of the hospice homes will have like central dining areas where families have complete access and can go in there, and while they're staying here they can cook their own meals or they can cook meals for their loved one. So it's a very collaborative model in terms of living for this person and or living with this person till death. You might say, well, why would somebody choose a hospice home over just having hospice at home? Sometimes it gets difficult for families to really arrange so that everybody can take turns and be available, depending on distance and things like that. So sometimes hospice care is not feasible because of just family resources are not as it should to cover somebody around the clock being with them. The other thing is sometimes you have an elderly spouse that's very ill and needs this level of service, and their spouse is there, but they're not physically fit to move or turn or roll them when someone's not there. And in that case, you know, they might need skilled care or they might need to go to the hospice home at some point. But in reality, hospice care it is going to be somewhat different than hospital care because the focus is not all on cure. The focus is on how do we make your symptoms more comfortable. Sometimes that might mean that you get medications. For example, medications that we don't normally give rectally might be mixed up and given rectally because your condition is such that you can't swallow, but they don't really keep, you know, intravenous lines and fluids in somebody all the time. They might put in some fluids to give some hydration if that was something that might be palatable for somebody. But you will even see pain medication given in a very different way. Patients often will have a PCA for pain, but it may be inserted as a subcutaneous infusion, much like an insulin pump would be, and then they have a cartridge that gets filled with their narcotic pain medication for that pump. So you're going to see some different variations, but in terms of quality of care between the hospice home and the skilled nursing facility, I think sometimes people think, I don't want to send my mother to a skilled nursing facility, and I don't want to send them to a hospice home, equating the level of care. In reality, most of the time, a nursing assignment in a hospice home is usually 5 patients. So, yeah, they don't have a lot of IV meds and a lot of different things going on, but they do spend quality time, just like this girl is there. They may be dressed in regular clothes instead of nursing uniforms to really make them feel more at home. So in that sense, it is different in a positive way, not in a negative way or equivalent to typically long, big assignments that you see in nursing facilities. Just put in a slide or two that shows the domains of palliative care. So, just be trying to make sure that you can identify which things that are interventions that would be physical care or psychological care, what care is social in terms of their interaction with the outside world or with their communities. Spiritual, religious, and existential aspects of care are very common, and I'll speak to that more in a moment. We also can determine that for palliation there are some cultural aspects of care, and it's always good to really, encourage people to just tell me more about your cultural needs in this case, and usually that's the best approach. And then there's actual care of the imminently dying, which is the bigger focus, and then some ethical and legal aspects of care that I'll mention shortly. So palliative care is symptom management, being aware and treating typical signs of distress, and make sure that you look through and you're really aware of, what would be the physical signs that you would see, the mental signs that you would see when somebody is in the 3 different stages of death. Early death stage, the middle dying stage, and then the imminently dying stage, because those are always important, and usually you're going to see test questions on those. And as I mentioned, you may see some of these different types of symptom management. You may have somebody that has a paracentesis or a thoracentesis to draw off fluid from the abdomen or the chest so that their work of breathing is improved. Sometimes patients get very low blood levels, and as a result, it's a big issue with their ability to function. And so it's for palliative care, patients can get blood transfusions. They may or may not be able to have those at hospice home centers. It just depends on whether they have a contract with the agencies that supply blood. So they might be sent to the emergency room or wherever to get a unit or 2 of blood and then come back. So family care and involvement, we covered this quite a bit, but in the case of a dying patient, you really want to evaluate, assess how well they understand the patient's diagnosis and that they actually are dying. When it gets where you can tell that they are in active dying phase, it's important to kind of start slow, but make them aware that the patient is beginning to show symptoms. that would lead you to believe that, because often they need to get people to come in, and so it's important that they make arrangements about that, and it gives them a moment to